Okay, so still talking about the cerebral cortex. We talked about sensory lesions. We talked about agnosia, which is the inability to distinguish sensations. Astereognosis, inability to identify something using touch. Visual agnosia, which is the inability to identify visual stimuli despite intact vision, and auditory agnosia, where you cannot identify sounds even though you can hear. Apraxia, dysarthria, and motor perseveration are part of motor cortex lesions, which we're going to talk about now. So we talked about the locations, functions, and disorders of the primary and secondary sensory areas of the cortex, and now we're going to describe the locations, functions, and disorders of the motor planning areas. So back to the localized functions of the cerebral cortex. We talked about the left half of this chart, the primary and secondary sensory cortices and the dysfunctions or the effects of lesions in those. And now we're going to talk about the motor planning areas. In the last module, we're going to talk more about lesions of the association cortex. So hopefully that makes sense to you. So we're going to skip the parts we've already gone over. Okay, so the primary motor cortex is the source of most of the neurons in the corticospinal tract. So the bodies of those neurons live in the primary motor cortex. Primary motor cortex is located just anterior to the central sulcus. So it's right next door, or right across the street from the primary somatosensory cortex. Isn't that interesting? And it's also somatotopically arranged. It controls contralateral voluntary movements, particularly fine movements of the hand and face. Just like the primary somatosensory cortex, a large portion of the primary motor cortex is dedicated to the hands and face. A much greater proportion of the total area of primary motor cortex is devoted to neurons that control hands and face than is devoted to the trunk and proximal limbs, where it's more gross motor activity that's required. In the hands and face, it's the fine motor activity. So lots of the primary motor cortex is dedicated to that fine motor activity. So here's the good old primary motor cortex, just anterior to the central sulcus, right across the street from the primary somatosensory cortex. The primary motor cortex, its function is voluntarily controlled movements. Lesions of the primary motor cortex cause paresis or loss of fine motor control. When it comes to speech, the result of the loss of motor control for speech is called dysarthria, spastic dysarthria. So dysarthria, you can still speak, but you don't have control of the fine qualities of speech. So it comes out as harsh, disorganized sound. The premotor area controls trunk and girdle muscles and anticipatory postural adjustments. Lesions of the premotor area cause apraxia. The supplementary motor area is the initiation of movement, orientation, planning, bimanual and sequential movements, and that also cause apraxia. And we'll talk specifically about apraxia and what the effects are. So you can think of it as you can't plan your movements, if you want to think of it that way. So it's a motor planning disorder. Broca's area, which we will talk about more in the upcoming module, it's motor programming of speech, and it's usually only in the left hemisphere. Broca's aphasia is usually a lesion in the left hemisphere, and we'll talk more about Broca's aphasia in the communication chapter. The anterior frontal gyrus of the primary motor cortex is usually in the right hemisphere, and it's in the analogous location to Broca's area. So Broca's is on the left, and the anterior frontal gyrus on the right plans nonverbal communication, emotional gestures, tone of voice, and it's, again, usually in the right hemisphere. So if you have a lesion there, you have difficulty producing nonverbal communication. So we'll talk more about those last two in the communication chapter, but they're both motor issues, speech motor issues, or communication motor issues. So damage to the primary motor cortex is characterized by contralateral paresis and loss of fractionation of movement. Dysarthria is a speech disorder resulting from spasticity or paresis of the muscles used for speech. So there are two different kinds of dysarthria: spastic dysarthria, which is hypertonic muscles, and flaccid dysarthria, which is hypotonic muscles. So when the muscles of speech are hypertonic, you get harsh, awkward speech. When the muscles of speech are hypotonic, you get breathy, soft, and imprecise speech. So two different types of dysarthria, and dysarthria is a motor speech disorder. And it's spasticity or paresis of the muscles used for speaking. So the cortex that's anterior to the primary motor cortex, just like the primary somatosensory cortex, just posterior to it is the secondary somatosensory cortex. Just anterior to the primary motor cortex has these planning areas. So the supplementary motor area is important for the initiation of movement, orientation of the eyes and head, and planning bimanual and sequential movements. The premotor area or premotor cortex controls trunk and girdle muscles via the medial motor tract neurons. And Broca's area is responsible for planning the movements of the mouth during speech and the grammatical aspects of language. So really interesting. So Broca's is basically the premotor area for speech. It's a motor planning area that is dedicated to the muscles of speech. Interesting, right? Premotor cortex lesions impair the speed and automaticity of reaching and grasping, sequential movements, and gait and posture. Obviously, three very important things. Motor planning area disorders cause apraxia, which is basically motor agnosia. You lose the ability to remember how to perform skilled movement. So all the movements that we do on a regular basis, like putting on our clothes and brushing our teeth and driving a car and all those things, even though you still have the motor or sensory ability to do those things, with apraxia you cannot plan how to do those things, so you lose skilled movement. Motor perseveration is uncontrollable repetition of something. So motor perseveration is uncontrollable repetition of a movement. So if you tell someone to lock their wheelchair brakes and they lock and unlock, lock and unlock, lock and unlock, that's motor perseveration. So doing the same repetitive movement over and over again, and it's uncontrollable. The person doesn't know they're doing it. Broca's aphasia is difficulty expressing oneself using language or symbols. So it's not just it is the motor planning area for speech, but it also has other functions in language. And we'll talk more about that in the communication chapter. So the association areas of the cerebral cortex are areas of the cortex that are not directly involved with sensation or movement. And that's pretty much everything else besides the areas that we've talked about. So lots of processing goes on in the association cortex. The signs and symptoms of stroke, and we talked about these in the last module, depend on the location and the size of the lesion. So you can see with all those specialized areas, if the stroke affects that area, all of the specialization in that area is going to be lost. So that's the same list that we went over before. More than 25% of people surviving brain infarctions have at least one of those deficits. So recovery from stroke, there's always, things going on. Ongoing controversy, they like to say in the book, about the long-term effectiveness of compensation, remediation, and motor control approaches to stroke rehabilitation. So there are lots of different approaches, and you will meet therapists that do different ones. Current research indicates that intensive task-specific therapy produces significantly better motor function compared with the remediation approach. So people on the average of 3 to 4 months post-stroke significantly improved on several measures after a task-specific program combined with patient self-identification of their own problems compared to a group that received a conventional remediation approach. So one of the things that I think is super relevant about this research, and compared to research I've read for other disorders, is that the patient identifies their own problems. That means you're doing something that's task-oriented and specific, and it's salient to the person who's doing it. So this task is important to that person. And I think that is, you are much more likely to get a better outcome if you're doing tasks that are salient to the person who is experiencing the rehab. So that is something to think about with all your patients. Is what we're doing important to that person? Are they motivated to get better at it? So hugely important for planning our therapeutic interventions.